Now, back to the history. Back there in '84 when we moved here, like Dwayne was saying, it was still seaside. It seemed, although I wasn't closely involved with the negotiations for the hospital, I knew they were going on, and it all seemed reasonable that the place needed replacing clearly, and there was lots of new regulations coming down, and it was too hard for these little rural hospitals to keep up with all the regulations. So it made sense to partner with a bigger corporation that could give the economic balancing. You know, they could get bigger bonds, and they could have a bigger stable of lawyers that can help with the regulations. But remember, this is loaned money. We've always paid our own way up here. They might have given us great financing to be able to build the new hospital, but this community paid for it over time. And so that's a lot of the other talk you hear about how much money Sutter Health puts into this community. But I can assure you, and we've done the research, this hospital has paid its way from the very beginning. And for the first 22 years, it went really well, actually. Everyone got along, and there were no big controversies. And then in the last few years, things just started to change. And I got interested in getting more involved with the hospital again because they had this posture that they were going to be very involved in the community. And in 2008, I joined the healthcare district, which is an elected position, and it was partnering with the hospital and with there was the newly formed Wild Rivers Community Foundation, who had gotten the California Endowment to come in, and the whole Building Healthy Communities initiative. And all this really good community partnership was being formed that was going to really transform, and it still is. And I say the healthcare district's doing a great job. That could be a whole topic for another town meeting, because I think it's a great example of 5 elected officials working closely together for the betterment of their community. We don't get much tax money, but we're really good at leveraging it with our other tax partners, or our other partners in the community, and we've really done a lot of really good stuff. And we could do a whole program on that. But they were doing great, and Sutter originally was participating, so much so that I was like, wow, I'm going to get more involved with the hospital, and so I got elected as chief of staff. And now the way the hospital board works is that the board is all appointed by Sutter Health, but they're appointed to fill a position, but they're supposed to have the community in mind. They're supposed to be overseers for the community. And the only elected person on the board is the chief of staff, who's elected by the medical staff of the hospital. So everyone else there is appointed by Sutter Health, and the chief of staff rotates every year or two, depending on who's chief of staff. So once I got on the hospital board, all of a sudden I was like, something's wrong here. It was just the oddest feeling. And I think to understand it, and this is important too for the rest of the evening, hospitals don't run like other businesses, in the sense that there's not just a linear chain of command. In a hospital, there's two columns of power, and one is the medical staff, and one is the business administration people. And the reason for that is because you're in patient care business, you need the medical staff as the protectors of patients. You don't want the bean counters reaching into deciding patient care. So this is a long-held, legal structure that autonomous medical staffs are very important, and they're very protected, and their responsibility is patient care, making sure that patients have the best care and that patient safety. It involves all the credentialing of physicians and re-credentialing and watchdog, and the physicians have to keep an eye on each other. So it's essential that that stays separate from business administration. As we get on with the evening, we're going to have Dr. Davis is going to be talking about the importance of a sovereign medical staff. And then Dr. Duncan's going to be talking more about all the business problems that are going to come up from regionalization. And then Mr. Costin's going to talk about the umbrella that goes over all that, which is the hospital board that's responsible for all of those things. And explaining how this system has become very dysfunctional and how there's plenty of hope and other models that we can follow once we get Sutter Health out of here. So I'm on the board, and just to give a couple of quick examples, almost my first chief of staff meeting, there was a patient care policy that they said, here, sign. The chief of staff hasn't signed off on this yet. And just to abbreviate it really quickly, it turns out this patient care policy was implemented a year earlier, and it had never gone through the local medical staff. It turned out came up from the region. And this was 3 years ago. It came up from the region. And I was like, well, this is a simple fix. This is wrong. We can't. And I could not get them to change it. I mean, it was a brick wall. And it was my first taste of what it is we're up against with these guys. I mean, a solid brick wall. They would not change it. And I was like, it's against the bylaws. It's against everything. Wouldn't change it. And that was on the medical staff side. On the business side, the third month in, they decided there was a local company that did some of the billing for Sutter Coast, medical billing. And they were doing a great job, no problem. They all of a sudden decided they had to outsource those jobs. They had a big central computer somewhere down south, and this computer was going to do the billing much better. And we have to do this. And I put up a huge fight. No, I mean, even if it could do it cheaper, you're losing local jobs. How can you guys do this? And same deal, brick wall, got nowhere with it. And the jobs left. And the real kicker to that is the computer system didn't work. And so they lost millions of dollars by doing this move. So I moved through my 2 years as chief, and then we get up closer to about September, and they start talking about officially regionalizing. And up till then, it was only this vague word of what is regionalizing. Hadn't even discussed it. And so I said at the hospital board meeting, this doesn't sound good, but I don't even know what it is. I mean, I guess I gotta owe it to you. I gotta at least educate myself and figure out what does this regionalization mean? And we said, okay, yeah, we gotta educate ourselves. So it was like the next month, they had the president of the region, who was this Dr. Brotman, who has since been just recently replaced by Mr. Cohill. So Dr. Brotman is not there anymore. And he came up and just basically gave a big fluff story about everything's going to be great, and it's going to work better in the region. And then they said, okay, that's good, then let's vote. And I was like, no, no, we still don't know anything. You got to at least go to the healthcare district and tell somebody about something. And they begrudgingly did. And so in last October, they came to our healthcare district meeting and gave us the same fluff, just everything's going to be better once this happens. And I remember I'm on the healthcare district also, so I'm sitting there at the healthcare district talking to Andy Ringgold and Judge Schaefer, who were the two board members who came from the hospital. And I'm like, you guys, you haven't studied it. You don't even know any of the details. You don't know how this this could hurt the community. It's like, oh no, it'll be okay. And I just kept fighting and fighting. And no, we have to study it. We need the details. We have to find out every way that this is going to hurt the community.